I don't think that our community is so diverse and so big that I don't think we always have to go back to the same people. This comes to how do we choose our guideline authorship. And I do think to some degree there should be more transparency on how we choose authors and how we try to give other people opportunities. And I think that that's when you dive into our paper, you see that those are some of our recommendations for the future, is that we want more transparency, more objective criteria for authorships in our guidelines, but with also an eye towards equity, diversity, and inclusion in the guidelines themselves, and also in our chairs, because we did find that when women were chairs of guidelines, there was definitely more diversity in the guidelines.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. So we've been wanting to do this one for a little bit, and because of our conflicting schedules, we haven't had a chance to do this episode, which is, I think is both celebratory for the paper that Dr. Rai published in Journal of the American Heart Association, was mentored by Dr. Gulati, and, what I believe is a very important paper. And we're going to talk more about the paper because this episode is focused on that paper. But before we begin, just brief introductions. I have with me on today's show, Dr. Devesh Rai and Dr. Martha Gulati. Dr. Devesh Rai is a first-year cardiology fellow at Rochester General Hospital. He also has a significant role with Cardio Nerds, which all of us know is a popular cardiology podcast show. Devesh is the deputy editor for the Journal Club section for Cardio Nerds, and Dr. Martha Gulati, of course, needs an introduction. She is the luminary cardiologist, is widely published, and has been a source of inspiration for not only women in cardiovascular medicine, but also men like myself and Devesh, and has mentored Devesh on this important manuscript. So with that introduction, Devesh and Martha, welcome on the show, and thank you for doing this for us.
Yeah, thanks for having us.
Thanks, Dr. Kalra, for the kind introduction.
Okay, great. So I'm going to start by asking Martha the first question, and that is sort of, I think, an important theme for the paper we're going to discuss on this episode. The paper is Gender Differences in International Cardiology Guideline Authorship, and it's a comparison of the US, Canadian, and European guidelines. But before we delve into the findings of the study, which was published in Journal of the American Heart Association, Martha, you also recently chaired and first authored the chest pain guidelines. So who better than you to actually describe and maybe educate us? Because, I don't think I know a lot about the guideline development process, and I'm sure our listeners would be keen to understand as to what really goes behind the scenes when it comes to guideline development from societies like the American College of Cardiology and the American Heart Association, among others.
Yeah, no, that's a great question. And I would say until I was involved in the guidelines, especially chairing guidelines, you learn a lot about this, what goes on in the background of every guideline selection. And I would say that, probably it's evolved over time. And of course, our study took place from 2006 to 2020. And I can't tell you specifically differences way back when, but what I can tell you about guidelines currently, at least for the American College of Cardiology and the American Heart Association, is there is an increased emphasis now on making sure we have a diverse workforce on the guidelines. Of course, they want experts, people in specific areas, whatever the topic is. Of course, that should be first and foremost, because why would anyone actually believe the guidelines if there's not an expert for the content? but a little bit of guidelines, depending on the other writing groups that they will invite. For example, for the chest pain guidelines, the ACC and the American Heart Association were the leaders of the guidelines, but we invited our partners. So, for example, American Society of Echocardiography was included, SCCT, the cardiac MRI people and the nuclear people were all invited to the table, as were our emergency physicians and our interventional colleagues, where everybody was, everyone that needed to be at the table, we tried to include at the table. Now, as a society, do we get to dictate who they nominate from those committees? No. But what we get to do is we ask them for more than one nomination. And a little bit of how you select people to be on your writing group, there might be many things. It may be diversity may be part of it. And whether we're talking about people underrepresented in medicine or women as well, you might be looking at them from that aspect. You also want to make sure they have the expertise, that they're going to be able to do the work. And quite honestly, sometimes we have to make sure our guidelines represent people without conflict of interest. So you have to have at least 51% of people on your writing group that do not have a conflict of interest. And some guidelines have gone to other extremes and said nobody can have a conflict, but we were given the number 51%. And so you probably tended towards getting a little bit better than that, because you never know if somebody might take up a conflict of interest while you're writing these guidelines. So those are all the many variables that come into play when you're looking at your writing group. But to think that a chair entirely gets to sort out who gets to be on the guidelines would be wrong. At least that was my perspective. Initially when I showed up, I was like, oh, I get to invite the people that I think are the experts. No, that's not exactly how it works.
Thank you for sort of educating us and sort of giving us a bit of an idea of what happens behind the scenes. It certainly is a very involved process, like you mentioned. And I think what's really good about it is, inviting other societies to be on the table. I think that's super important. So that you have all the, key opinion leaders or stakeholders, at the same table making the right decisions for this to be sort of immortalized in a document, like a guideline document, which is a very important document, is downloaded and read by clinicians at the bedside taking care of patients. And it really, informs patient care and probably affects patient care. So I think it's an extremely responsible position to be in. And I'm sure it's a ton of work. Now, before we sort of get into our paper, and this is for you again, Martha, what do you think is a typical timeline for a guideline document from the time of its inception to the time it actually gets published? What is the mean or median time frame, and how hard it is to sort of keep accruing more evidence into the guideline document, because like evidence generation does not wait for the guideline document to be published, right?
Yeah, well, that's a great question. And I would say every country does things a little differently. I would say the European guidelines are much faster. They put a group together, they work on writing, and in less than 6 months often, they have a published document. In the United States, it's a lot more bureaucratic and it's taken a lot longer. And there's been complaints about that too. I would say our chest pain guidelines took us 4 years. And anytime there's a controversy, as there was in our guidelines, it takes longer. Everyone knows about the hypertension guidelines. That we were waiting for so long for JNC, what was supposed to be JNC 8, that got nicknamed JNC late because it was many, many, many years. And same with the lipid guidelines, the same thing. There was a lot of controversy about them, and that caused, you have to work out if you can't even get a consensus in your writing group, that's part of the issue. If people reviewing on the review panel, and you get to have some say on the reviewing panel, but you want people to criticize them before they go public. And if they find problems with what you've written, you also have to go back sometimes to the drawing table. But the problem with US guidelines, in my humble opinion, is that it does take us a long time. And then by the time they come out, you already have other papers you wish you could already, add to, or maybe to even change your guidelines based on something. The Canadian Cardiovascular Society, which we also included in our analysis here, I know less about in terms of what their timelines are. But these are things that, of course, play into whatever guidelines coming out. Sometimes it's straightforward. Sometimes the task is simple. We want a guideline on some, very narrow part of how should we practice. Sometimes when our guidelines are as vague as a symptom, which is what the chest pain guidelines were, they were the first symptom-based guideline, that can be a much harder task. So, we might be criticized for how long we took to write the chest pain guidelines, but we've been very public about why we went back to the drawing board as well.
Yeah, no, thank you again for answering that so eloquently. And, I certainly don't envy any of the guideline chairs to be in that position, because it's just a lot of, like you said, it's a bureaucratic process, and sort of everybody needs to be on the same page, and there's resolution and controversy, and then there's criticism or critiquing by the reviewers, and it's an involved process, and I'm not sure I probably have the patience to endure such a process, but maybe I will in the future. I'm not even certain. But with that preamble, thank you so much for educating us, Martha. But I think it's a good segue into asking Devesh the question about the paper that he published. And, thank you so much for considering me to be a part of the author panel, a very esteemed author panel, from Europe and as well as from North America. Devesh, what was it that inspired this question at the first place for you as a first author, as a primary investigator on the study? How did you think about this question? I mean, it's a great question to answer, and you did it beautifully. But how did you think about this question at the first place?
So, the crux of this question mainly goes to if I go back about the underrepresentation of women in medicine and women in cardiology. I'm married to a physician. My wife is a third-year resident, and back in my medical school, or in a class of 75 people, only 19 were guys, and everybody else was women. So back in medical school, I never felt there's a underrepresentation of women in medicine for some reason, because the boys were underrepresented in that. But when I came to US to do residency and medical residency, and I was getting training, and I saw that a lot of times I'll have senior residents who are women, and the patients will direct their questions to me for some reason, or even at times nursing will direct the questions to me. And I felt this disparity among men and women in medicine, that even as I'm an intern and I don't know most of the questions, they're directed to me rather than to my senior resident, who's a woman and she knows much more than me. And probably every time I'll reach out to her to answer those questions. So I started to observe that, and it continued to happen. And then I looked into data, and I saw some papers that when women treat women, the outcomes are much better. And it goes even for underrepresented race and ethnicity too. When Spanish-speaking providers treat Spanish-speaking patients, the outcomes are better. And that's where I was okay, let's take a look at guideline authors, how, and that's we are doing at the patient level, but how are we doing it from the documents which are prepared by authors? How are we doing at that level? Because as it has been shown in the past research, that people who treat from the same background, the outcomes are better. And I wanted to do this for a while I was in second year of medical, residency. And I discussed this with a couple of friends, and then they were no, you don't want to make enemies, because if you say that cardiology is a male-dominant field, you should not be doing that. And I continued to think for 1 year, and then I reached out to Dr. Gulati and Dr. Michos that I want to do this. And the response was like great, that okay, yeah, we should do this for sure. Nobody's gonna like blame you for doing this. And after that, we started to look into this more and more, and we published this paper. And until now, like I have not had a single bad comment from anybody that you are a guy, why you're writing about women in medicine and women in cardiology. In fact, I have always got like people like from you and other people that, no, this is a great topic, you should keep working on this topic. So that's how I got interested, and I want to continue working in this field for sure.
And I would add to that, if I could, that Dev really, I was kind of surprised when he said that this is the topic he wanted to look at and dive into. And we've written quite a few papers now in this area, but I would say it really was under his leadership. I just got to sit back and enjoy the ride. He actually had this question and wanted to dive into it. And there's nothing greater to see our next generation of he's for she's really asking the right questions, because I think what Dev really wants is to make a level playing field for everyone.
Yeah, no, I mean, it was a great topic. I mean, I think when the manuscript in its earlier iteration came to me for commenting as an invited co-author, I was quite frankly honored. I was in awe of the topic, and I think just the way it was put together and done was great. So, Devesh and Ashish, with whom I've worked very closely with, so to both of you, congratulations, and again, thanks for including me. So in this analysis, Devesh, you include. So it's over a decade, so it's from 2006 to 2020, like Martha said earlier in the show. And you've included quite a bit of guidelines. I mean, you've included 80 ACC-AHA guidelines, there are 64 Canadian Cardiovascular Society guidelines, and there are 59 European guidelines. So that's a lot of analysis to be done. And then you what you did was you basically looked at trends in inclusion of women across the spectrum of all these guidelines. So do you want to walk us through this process? How did you go about picking these guidelines, and how did you put them together, and what you found? So essentially, I'm sort of preaching to the choir, like you direct the journal club section. So we're essentially doing a journal club on your paper. So, just go over the methods and the results, because I think these are very important results to be shared with our listenership.
Yeah, so finding the guidelines was kind of the easy part, because first of all, the ACC, either it's ACC or AHA, Canadian guidelines from Canadian Cardiovascular Society or European guidelines, they are publicly available. And for ACC and AHA, on the ACC website, they put only the recent guidelines, and they remove the older guidelines which are currently not in use. But they always cite the older guidelines in their current guidelines. And we also looked at the PubMed to find all the guidelines so that we are not missing any. The reason why ACC has 80 guidelines, because we also included the ACLS and BLS guidelines, which are published essentially by AHA. So that's why we have a lot of guidelines in that. And then for Canadian guidelines, they keep a bibliography of all their guidelines published in the past couple of decades on their website. So that was very easy to find. And same thing for Europeans too, it is available on their website. Thereafter, the toughest part was like finding the gender of all the authors. So we had for every guidelines, there were two authors from our paper who looked at the gender of the authors. And primarily, like every guideline has two committees, and we just included the committee which writes the guidelines. Like ACC has writing group and a task force. Similarly, if we talk, and this writing group is the one which writes the guidelines, and Dr. Gulati can correct me if I'm wrong on this. And for Canadian guidelines, they have a primary panel and a secondary panel. So essentially, the primary panel of Canadian guidelines is something similar to the writing group of ACC guidelines. And for the European guidelines, they call them task force and document reviewers. And task force is the one who writes the guidelines. So for what we observed, that for all these guidelines, like the second group, like the task force for ACC or secondary panel for CCS and document reviewers for ESC, they remain same for the year. They get appointed for 1 year or 2 years, depending on Canadians, they get appointed for 3 years. And they they find that they assign the chair, and they choose the writing group, the people who will be writing the guidelines, along with every society has a different approach to write the guidelines, and of course there's a lot of other things which we don't know, like how it goes to choose the chair, and how definitely they are the experts in that area. And so once we found all these authors, we looked at mostly, we Googled them, and we looked at their social media profile or the university bio page to find out what gender they are. And that was done in pairs independently, and we made sure that there's concordance. Like if there was not, then we went back and looked at it again. We were able to find the gender of all the authors. And essentially from ACC, we found from the 80 guidelines, we found that there's total 88 authors. And out of those, only 28% are women in over 15 years span period. For Canadian guidelines, there was 64 guidelines, and we have 988 authors, and 26% were women. And if we go for European guidelines, there are only 59 guidelines with 1157 authors, and 16% were women. So if we see like that, like ACC had the highest number of women, and followed by CCS and European guidelines. The next thing, so finding this was one of the major aspects where we looked at, okay, the disparity exists, and definitely it's about on an average, if we think like that, it's like 25% are women and 75% are men. So that was one of our primary findings. The next thing what we chose to do is we also looked at multiple things, but the one interesting aspect what we looked at is how's the trend from like 2006 to 2020, like from yearly changes, how it is. So in ACC, we found we started in 2006 with 12.6%, and now we are at 42.6% in 2020. And the stats was statistically significant with p-value of 0.005. And when we looked at European guidelines, it was 7.1% in 2006 and went up to 25.8%. And the P was 0.04, with the average annual percentage change was like 6.6%. However, when we looked at Canadian guidelines, the interesting aspect was the Canadian guidelines started really high, 20% in 2006, and went up to 36%. In spite of the number per percentage, looks like there's a 16% change, but the p-value was not significant for that, as it was 0.09. So that was one of our main findings, where we looked at the trend over 15 years and how we are doing among all these guidelines.
Yeah, do you have any comments on the results there, Martha?
Yeah, I mean, we have to take these with how many women are in cardiology. I mean, we know that our numbers have really not grown significantly, even from 2006 to 2020. It's been a very small increase. So we're understanding that, this is to reflect on where we are and where we can go, because we know that another issue that comes into where are the experts who have been leading the clinical trials. Well, we know from other work done by Harriet Van Spal and others have looked at this, that, we don't have as many women leading clinical trials. So of course, they're not going to be asked, if you're not leading the clinical trial, you're not going to be asked to necessarily be on guidelines. So there's a lot of issues that weigh into these numbers. Additionally, I mean, although it looks like our numbers are increasing, especially in the United States, we went, as Dev said, from 12.6% in 2006 women to 42.6% in 2020. That's a remarkable change. And I think in the US, we've been doing better. But I think that often we would see on guidelines where there's a lot of MDs who are men on guidelines, often the women might be PhDs, not to minimize PhD roles, but it's interesting that they'll go outside to search for a PhD, but there's also a lot of cardiologists who are women that should also be considered when they are trying to make a more diverse workforce. The other part that I think Dev left out was just even repeat authors. And we did see this thing of repeat authorship over time, and it happens all over the world, partially because we update guidelines, we do more research, and we say, okay, we got to redo these guidelines. And sometimes they bring in people who were on the guidelines before, so they have a historical perspective and can help sort of shape what's changed, and that's important. But we even had in the US guidelines, so the ACC-HA guidelines, there was one person who 20 times had been on guidelines. There's no such similar numbers for women. Most of the repeat authorships were actually in men, and often they were 5 or more, like, they'd been on 5 or more guidelines. Now, it's one thing if everyone's an expert, if there's one person who is a really strong expert on multiple topics, that they get invited to be on multiple guidelines. But I don't think that our community is so diverse and so big that I don't think we always have to go back to the same people. This comes to how do we choose our guideline authorship. And I do think to some degree there should be more transparency on how we choose authors and how we try to give other people opportunities. And I think that that's when you dive into our paper, you see that those are some of our recommendations for the future, is that we want more transparency, more objective criteria for authorships in our guidelines, but with also an eye towards equity, diversity, and inclusion in the guidelines themselves, and also in our chairs, because we did find that when women were chairs of guidelines, there was definitely more diversity in the guidelines. Wasn't that true, Dev?
Yeah. So those were the next findings. What we saw is for overall, if it's saw for chair wise, like in ACC guidelines, only 22% of times women are chair. For Canadians, it's 16%, and for European guidelines, it's only 7%. But we also looked at what if women as chairs, does that impacts how's the composition? And when women are chair in ACC guidelines, 48% of the authors are women. And even when we saw that some guidelines have co-chairs, there's one men and the other is women. And even in that situation, there were more women included in the guideline committees. And this was true for ACC and European guidelines, but not true for Canadian guidelines. So that was another interesting aspect, that even though chair does not get to cherry pick who comes on these guidelines, but there's some inherent bias or something there, which when the women is chair, there are more women on the guideline committees. So it's not like there are not enough women to write guidelines. It's just that they don't get picked often. That might be true.
Yeah, no. So so it's fascinating that Devesh independently found this, and in investigating the diversity with guidelines, when we reported a similar observation in trials that are being led by women, in that when women are first authors in randomized clinical trials, the sub-studies that are published from that trial, for example, a post-hoc or a secondary analysis from pre-specified endpoints, women tend to share that first authorship position with, other women. Unfortunately, the same is not true for men. So when you would have a randomized clinical trial being published in the New England Journal, or for example in JAHA, and then you have these sub-studies from these randomized clinical trials looking at pre-specified endpoints, or certain diverse groups where the findings were different. Men who were first authors on the randomized clinical trial were first authors on these sub-studies also. Now that was different with women. And that's something which we reported when we published this paper now, I think it was about a year ago in JAMA Open. So it's kind of interesting that a similar theme comes across even when you are looking at guideline documents. Do you have any comments on that, Martha?
No, I mean, what can we say? I think we want as a community, just these messages to get out so that everyone can be more inclusive. I don't, it is true that women tend to be more inclusive and tend to, invite other women to be part on their guidelines, tend to also look for more diverse people to be on their guidelines that are underrepresented typically in our cardiology community. But it needs to transcend who's the chair. And again, these are our statistics. We're just the reporters.
Yeah, excellent. Now, I'm going to also ask Devesh this question on subspecialties, because I think that's an important component of the results section, the 5-year trends in cardiology subspecialties, which has been, reported in a very detailed fashion in the manuscript. And, for those who are listening, we are going to be providing links to this publication in the show notes section. So, feel free to download the paper, when you are listening to this episode. But Devesh, do you have any comments on trends you reported in the cardiology subspecialties? Because again, and this is from what has been reported and what's out there, in that the trickle effect and the dropout rate for women continues to increase, right? So the trickle effect gets, there is no trickle effect in subspecialties, and the dropout rate for women continues to increase, meaning less and less women are pursuing subspecialties. I really hope that changes, but certainly in interventional cardiology, for example, I mean, it's in single digits. Maybe the same is true for EP. I don't have the numbers up on me, but and maybe you and Martha can expand on this. But what did you find with subspecialty guidelines?
So when we looked at, so that's a really interesting question, Dr. Kalra. And as you said, mostly the percentage of women in the interventional cardiology and EPs on the lowest side compared to other guidelines. And we looked into general cardiology versus subspecialties. Overall in general cardiology, this was true for almost every society. So I won't go into deep numbers, but in American guidelines, in general cardiology, women are about 30%, but in pediatric and heart failure, they were close to 40% in US guidelines. And this was true for Canadians too, except in European guidelines, they were close to 27 and 15%. But if we talk about EP or interventional cardiology, the numbers are on the very lower side. Or in the EP, it was 22%, in interventional cardiology, only 19%. And if we think that, it is comparatively higher than the number of women pursuing interventional cardiology right now as a fellowship, because the numbers are close to 10%. As a recent paper I saw, it was 10 or 12% in interventional, and in EP it's close to 14-15%, so definitely lower. And it has been proposed multiple times that what could be the reason why women shy away from interventional cardiology, electrophysiology, and there is a multiple explanation for sure, but a couple of which I have seen more prominent is it's a very, very male-dominant field. The hours are long, there's radiation exposure, and not a good lifestyle. But the other interesting part, what we saw, or we cited a couple of papers in our study, is as per a survey from internal medicine residents and cardiology fellows, that why people don't go to all these specialties, lack of mentorship, and the other thing what they saw is they don't connect with somebody. So there's very popular saying you can't be what you can't see. So that's why one of the proposals what we proposed in our paper is we need to increase the visibility of the leadership. There are more leaders in interventional cardiology, electrophysiology from women in cardiology. There will be much more students interested in pursuing these fields. And the other thing is we talk about leaky pipeline and trickle effect. So mostly we need to start the actions not only at the stage of cardiology fellowship or internal medicine residency. I think this goes all the way back to medical school, or even before that we need to educate students at or incite interest at a very early age for students that cardiology is an exciting field and we all love it, and you guys all should try to go into this field rather than starting to educate medical students or residents when they have already made up their mind. And because at that stage you already start to think about what do you want to do, and there is the bias effects of like cardiology, the male dominant field, starts to grow on this women in medicine. So maybe if we start early, we can stop that bias effect.
Well, and I would like to say that it's never been the work and it's never been the hours. I mean, that is not why women don't go into cardiology, and that's not why women don't choose EP or interventional cardiology. I mean, I think that really it's what Dev said was the latter explanation, that they aren't mentored, they aren't invited in, and they don't see people that look like them. And sometimes that can be enough for them to say, well, then if other women aren't doing it, then maybe it's just not, the environment is not for me, or it's a toxic environment, that, they're not welcoming to women, and then they don't go into those fields. But I think what was great about seeing in our guidelines is that there's actually more women represented in guidelines in EP and interventional cardiology than there actually are percent women in the field. And I think that our societies have been making a greater effort of trying to be inclusive and inviting more people to the table, and recognizing that when we don't have women in the leadership positions, which guidelines are leadership positions, then their visibility will continue to be less. And the more that we can have them leading guidelines, leading trials, leading any aspect of our community, it can be a change, because people will see them in these leadership positions and say, that could be me one day, and maybe I will join. I do agree with Dev that we have to go way before even medical school. And we've done programs, and I've seen other people starting them, but we were one of the first programs when I was at Northwestern University. We started a program for inner city women, for girls in high school. And we actually invited them to what we called cardiology camp for a week. And I've replicated this at all the places I've been, where we've brought in people who might never have the opportunity to think about medicine as a career, and show them what people do in the cardiology field. Literally every aspect. Maybe some will become cardiologists. Maybe some will become sonographers. Maybe some will become dietitians. And I'm very fortunate to have followed the careers of many of these young women that have gone on to do great things within the healthcare field, that maybe just showing them that there's a place for them, and being able to see themselves in those careers makes a difference. And I think anybody who has these kind of programs going on throughout the country and throughout the world will really make a difference to changing the face of cardiology.
So that's a great comment, Martha. So as a segue to what you said, for someone who asks you the question, okay, we get it, DEIB, which is diversity, equity, inclusion and belonging, has become the buzzword. We get it. Great paper, we get the message, but I'm going to play the devil's advocate, and I'm going to say that, okay, but despite us being non-diverse, in your opinion, we've still made great strides within cardiovascular medicine and cardiology and medicine overall. Why is diversity, equity, inclusion, and belonging becoming so important now? Like, why is it that people are talking about it so much now? Why is it that, you guys are even publishing this paper now? Why now? And why is it that diversity is so important? How would you respond to people?
Yeah, I would say we've been talking about this for actually many, 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 many years. It has often fallen on deaf ears. And I think more recently, we are changing as a culture and as a community to recognize that, there are real issues. We haven't moved the needle as much as we need to in our cardiology community. And the American College of Cardiology has really put their money where their passion is, to say, okay, how are we going to change it? We've done, Black men in cardiology, Hispanics in cardiology, women in cardiology. Now, basically, people have been chosen in the internal medicine saying they might be interested. Well, let's bring you in and show you what it is and why it's a great career. And I think, that outspoken advocacy for diversity and equity inclusion has really helped. I mean, I think it's creating a culture where people feel like, yes, I'm part of something bigger, and I'm part of something that needs me, that wants me. But I will say that, for years we've been talking about this. And why have we been talking about it? We didn't look like our patient populations. We take care of men and women. We take care of people of a variety of races in the United States and in other countries. Our world is much more global. And how can we appreciate the differences? And when we continue to publish and report, women do less well after an acute myocardial infarction. Women are less likely to get guideline-directed care. Blacks do worse after acute myocardial infarction. Hispanics have more diabetes and also do worse after acute myocardial infarction. South Asians do worse. Well, all of that, we need people to be helping us connect with those communities who look like our patients, so they trust the cardiology community. I'm not saying that you have to treat somebody who looks like you, but I think by having a more diversified community, you become a better doctor, a better cardiologist. You appreciate the differences and the similarities, and you know how to communicate with people who are different than you. And we have so many gaps to close, and we know that it's because as a community, we really haven't moved the needle quite the way we should have. And I think that's why it's come to more light recently, is because everyone's talking about it, but nothing was happening. Let's see in the next few years now that we're really making these outward efforts to change the numbers, that we don't, that all this work is either effective or it's not. I hope it's going to be effective. I really believe it's going to be effective. We've just been watching in the last few days people matching and for residency positions, and I've just been blown away by people of so many different backgrounds that were not reflected in all kinds of specialties, that suddenly, since we're talking about inclusion, since we're talking about diversity, since we're talking about equity, we're seeing changes in the new generation of physicians of every specialty.
Yeah, no, that's a terrific answer. Thank you for speaking so passionately about this. I mean, there's a reason why I asked you this question, Martha. So thank you for doing justice to my question. That was terrific. Any closing thoughts on the paper? Any remarks? Anything you think I should have asked that I haven't asked about the paper?
There's one more point just to add. I mean, as we talked about, like in the EP and interventional cardiology, there is less women in cardiology, less women in overall. But if we talk about a pediatric cardiology or heart failure, there are almost 40% of women on the guideline committee. So that just shows that we have women in cardiology and or in medicine who are interested. And as like heart failure has been traditionally called a women-dominant field from Dr. Hayes and everybody else. And same because pediatric cardiology, because a lot of people who go to pediatrics, they go to pediatric cardiology or one of those things. So if we, as I said earlier, that you can't be what you can't see. So if we continue to promote, we need to just promote and encourage women in medicine from all aspects to bridge the gap. That's the last point for me.
Yeah, and I would say my last point is we are making strides. These are better numbers. If you look at the time trends, particularly in the United States, we have made change and will continue to make change with a concerted effort. I think that if there's people listening to this, if they're practicing cardiologists, to remember why we want a diverse workforce and how it's going to be better for our patients, So invite people in, invite people from diverse backgrounds in, invite women in. Let's be the change we want to see and what our patients really deserve. And then for people that are listening to this podcast who are still trying to figure out, what do they want to do when they grow up and they are considering cardiology, I would tell them that this is your time, especially if you're a woman or you're from a diverse background that's underrepresented. We want you here. We're all ready to mentor you. It is the best career. It is the best specialty within medicine. And we are here to encourage you and make sure you're welcome.
Yeah, excellent. You ended the show with my favorite quote from Mahatma Gandhi, and that is, be the change. So Dave and Martha, thanks again for your time and for taking us through this important and excellent work from both of you, which was published earlier this year in Journal of the American Heart Association. Like I said, we are going to share this in our show notes. So do get a chance to open the paper when you are, listening to this podcast. If you're driving, that's obviously a separate issue. But with that, I'm going to end the show. Dave and Martha, thanks again. And, we look forward to having you both on the show sometime soon.
No, thank you for having us, Ankur.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.